Good morning. This is the voiceover PowerPoint for NURS 1112 Health Assessment. This is Chapter 1. We will not be able to have enough time in class to actually cover this, so this will be your opportunity to take advantage of the information. And I will be posting this on a YouTube channel for you. So Chapter 1 is the Introduction to Health Assessment. Here are our student learning outcomes, and I would like you particularly to pay attention to what is a health assessment. We'll be talking about that in just a minute. The components. It's very, very important that you differentiate between subjective and objective data, and we will be talking more about that in our first class session as well. There's different situations where there's a certain type of a health assessment approach that's done. Types of health assessments done by the registered nurse. And then, of course, we always want to talk about how important it is to document in an accurate, timely manner. Pardon me. So, why do you need to learn an assessment? Well, first of all, the nurse is usually the first person to encounter a patient in the healthcare system. It may be, the medical assistant may initially take the vital signs or whatever, but the nurse in the hospital is the one who will initially see the patient. Many times if patients are admitted, they don't see the physician for a while. So it just depends on what's going on with the patient, why they're there. And so why do we need to do an assessment? Well, it's the beginning point of entry to the healthcare facility and healthcare arena, if you want to call it that. And RNs are continually assessing their patient's status throughout the day. So it's vital that you learn assessment techniques because you'll be using them every minute of every day of your nursing practice. They are vital and critical to your success. And so by gathering this health assessment data, we'll be talking a little bit more about that again throughout the class, we will be gathering data, and based on our data, that helps us develop a patient-centered plan of care. Now, in nursing school, you write these care plans out on paper or in an electronic health record on ATI. In real life, they're not really done that way, but after you learn how to do these things, they will become a part of your brain, if you will, and you won't have to write them down. You'll know what you're going to do. We use the American Nurses Association Standards of Practice, and that is something that guides us as well as our Nurse Practice Act in the state we are in, our hospital facility policies, all of those things. But the American Nurses Association does talk about the Standards of Practice, which talks about the nursing process, which health assessment is a part of. A health assessment must be done in a very organized, systematic manner. We usually do head to toe. We start at the head and we work the way down to the feet. And so skillful assessment is very critical to quality patient care. And practice is how you become excellent with your nursing assessment skills. Now, when we're talking about a nursing assessment, let's just talk a little bit about how it differs from a doctor approach. When the nurse does a physical assessment, of course, we do vital signs. We measure the height and the weight. We assess the vital signs. We do the heart, the lungs, all the systems we do. We do a health history. That'll come a little bit later as well. But the nursing physical assessment is an identification by the nurse of the needs, the preferences, and the abilities of a patient. Remember, patients don't come to us completely helpless most of the time. They have something that is a strength that they are able to do. We also want to keep in mind their preferences. Maybe we want to give the bath in the morning, but the patient prefers to have their bath in the evening, and that is certainly acceptable. We can do that very easily. And then, of course, we're talking about their needs. Are they anxious? Are they angry? Are they depressed? Those are needs that the nurse identifies, and that's going to have to be something that we incorporate in our plan of care, because we will be dealing with that with the patient throughout our day. We do a little bit of an interview, and we provide, based on our findings, along with lab results, x-rays, CAT scans, etc., we put all of that together, and then we come up with a comprehensive patient-centered plan of care. Now, a medical examination consists of the doctor has to know what's normal and measure these patients' current condition against these norms. They don't concern themselves so much with the needs of the patients as what's going on, what's the disease process, and how we can get them back to where they need to be, and that helps them determine a diagnosis, a medical diagnosis. Now, based on our health assessment data, and you'll be hearing this all throughout your course of study here, is something called a nursing diagnosis. And the nursing diagnosis is, nurses are concerned with how these health problems of this patient, how does it impact them? How does it affect them? Maybe how it affects their response to their problem. Maybe they're a big part of their family, and their being in the hospital is just really upsetting the whole family unit. Maybe it's a single mom, and she has 3 young children at home, and she's in the hospital, and she is worried to death about who's going to take care of her kids and how in the world is she going to pay for this bill. That is totally different than her disease process. That is something the nurse will have to intervene for, maybe by putting her in touch with the discharge planner or the social service people. That's the difference between a nursing diagnosis and a medical diagnosis. And you will hear more and more and more about that throughout your program. So I just wanted to put that in there, maybe to give you some background information and help you with that. And so the 3 components of a nursing component of a health assessment by the registered nurse is the history, which is called the subjective data, and the physical examination, objective data, and then then documentation of the data. So while we're here, and I'm going to give you a handout for this, let's talk a little bit about what subjective and objective data is. Subjective is what the patient or the person says about him or herself during obtaining the health history, okay? They may say things like, I've got a terrible headache. Well, we have no device to measure the severity of the headache. We have to take their word for it. That's what they say, okay? It's based on the patient's experience and perceptions. It includes feelings, sensations, and can only be verified by the patient. One of those subjective data is pain. Pain is very subjective. The way people perceive pain varies from patient to patient. And so they may talk about their feelings. I'm worried. I'm very sad. I don't know what's going to happen. Sensations. Oh, it's a burning. It's a tingling. It's sharp. Whatever. It's what they say. It cannot be measured. There's no tool that we have to measure the severity or the minor basis of their problem. Whereas objective is directly observed or obtained by the examiner. So for instance, they may say, I've got a sore on my right arm. Okay, then the nurse looks at the right arm and notices there is a significant amount of redness on the right arm. That becomes, at that point, the nurse says, that is definitely red. That's objective. I can see it. I can take my measurement. I can take a picture of it, whatever my facility says. We can look at the patient and gather a lot of information from something we call the general inspection or the general survey when you first meet the patient. We'll go over this in detail. Your vital signs, your height and weight, listening to the heart, the lungs, doing that physical assessment, because these are all things that are measurable. I can listen to someone's lungs and declare them to be clear of any fluid or extra sound. Or I can say, ooh, I heard some wheezing. That is something I can actually document. So subjective is what the patient says. Objective is what we can gather by measuring, by observation, by examination. And then, of course, we always have to document what we saw, what we heard, what we felt, what we smelled, etc. Pardon me. So here's some more about the health assessment components. Data collection, symptoms. Okay, that's another word for what the patient says or communicates. Signs, clinical findings. There's your objective, collected during your examination. Clinical manifestations, signs and or symptoms, collected utilizing inspection, palpation, percussion, and auscultation, which we will talk about in depth on Friday. Documentation is very, very important, especially when you first meet your patient. You have to have what we call a baseline. Where are they at the moment we met them? What do they look like? What are their vital signs? What's their current weight? Etc., etc. And we have to put this in our health record because it becomes a legal document at that point in time. So accuracy and timeliness, getting it in there in a timely manner. Don't wait till the end of your shift to document. That is the worst thing you can do. You need to document as much as you can as you go. It also gives us a baseline again for evaluation. Evaluation is part of the nursing process. It's like Debbie said yesterday. Did what I do for my patient work? Did it make him feel better? Did it change his situation? Did it minimize his discomfort? Or do I need to do something different next time? Our documentation has to be accurate, concise, no bias or opinion, and it really needs to be done at the time of care. Now, if you're in an emergency situation, you have someone having an active heart attack, you might have to just jot down things and go back and do more documentation as your time allows. So in certain situations, you may have to wait a bit, but you need to do it as quickly as you can. So we're talking about the types of health assessments. It could depend on the context of care. There you go. It could be an emergency. It could be something that is non-emergent but important. Or it could be a clinic setting where your patients may be coming in for health, a physical, and they have no real urgent problems. So it depends on what you're looking at and what your situation is. What does the patient need? Obviously, if the patient is short of breath or is having active chest pain, we've got to intervene right away. And some of our health assessment may be very emergent based and be a little bit different, but we have to adapt. And then, of course, the expertise of the nurse. As a novice nurse, which is what you are right now, you would not want to attempt to do an extensive neurologic exam. You have not had that content. You do not know the components. But you could certainly take some vital signs, or you could certainly help get the height and the weight, those kind of things. And here's more about the context of care, and you can look at that on your own, and you can read about it in Chapter 1. So here's a type of assessment, a comprehensive or complete, if you want to call it that, health assessment. That means that first encounter, maybe you've experienced this when you went to the doctor for the first time. They ask you to fill out all kinds of forms, and do you have this disease, and do you have that disease? And in the hospital, you'll have it on a computer, and you'll just go, you'll learn it, you'll go from screen to screen, and you'll click and you'll ask the right kinds of questions, and so forth, okay? So that's when you get a lot of biographical data and all kinds of things. So we'll look at that again as we go along, but you need to know these types of assessments. The comprehensive or complete, if you want to call it that, they're basically kind of interchangeable terms. We have the problem-based or the focused health assessment. Now, when you meet your patient in the hospital and you're admitting them, you get this comprehensive health assessment. And then the next time you go in and see your patient, maybe they're stable, you go out and you look at your doctor's orders and you begin to think about how you're going to implement what the doctor has written. And you've noticed in your physical assessment that that patient has some crackles in their lungs and they're coughing and they have nasty sputum and they're looking kind of sick. And so the next time you go in, you don't have to do this complete health assessment again. You are going to focus on the areas of your assessment that you notice were not within normal ranges, such as those lung sounds. Maybe when you check the feet, you notice some swelling. Those are things that you're going to go back and focus on, and maybe some of the other body systems as well. So it's a focused health assessment, which we do a lot in inpatient hospitalized patients. An episodic assessment might be, if they have an episode of some sort, or you're just going back just to check them. Maybe your patient's had a procedure and you're watching for bleeding. You won't necessarily have to go in and do a complete head to toe, but you want to keep an eye on that site that you're watching and those sort of things. There's screening assessments, which we do a lot in pediatrics. And then there's one that is not mentioned here, but I feel like we should talk about it. It's that emergency base. And that's when maybe you're working in the ER and you can have an ambulance coming in with a full code. We're doing chest compressions, we're doing ventilations, we've got the whole thing going on. Obviously, you're not going to ask this patient all kinds of questions because they're probably going to be unconscious, unresponsive, and you are going to have to do what needs to be done. And that's when it's an all hands on deck situation. Everybody is helping, and everybody is someone is writing things down. You have a scribe maybe, or you have an orientee, and you say to your orientee, hey, you document everything we're doing. You write down these vital signs. You write down every time we give a medicine. And then after the patient is stabilized, then we can tackle all these other types of assessments. So again, you can see how it really depends on what's going on with your patient, how in depth or how extensive you need to do an assessment. But I believe that every patient, regardless of the reason they are hospitalized, needs a complete or a good head-to-toe assessment by the nurse at the beginning of the shift when you come on. I don't care if they're there for a hangnail, they still need a head-to-toe assessment when you first meet them they've been admitted, all the other comprehensive and health histories, all that's been documented, and you know some of that information. You go in and you still do your head-to-toe assessment so that you know what's going on with your patient when you take over their care. And you'll hear more about that. I keep saying that, but it really is true. Patient needs. Of course, every patient is unique. Patients do not fit into nice little categories. There's no cookie cutter approach for patients. So the health assessment performed by the NURS is what is driven by the patient's needs, and we've talked about that. The nurse has to be prepared to conduct the right kind of assessment, and you take into consideration their age. Obviously, the very, very young and the very, very old, you're going to have to adapt things. The general level of health, are they stable? Are they unstable? Do you have priority problems you need to manage before you go any further? Those type of things. What's their problem? Presenting problems, lots of times you'll see it documented as their chief complaint or their reason for seeking help. You ask them, hey, what's going on with you today? What happened that you had to come to the hospital? And you can write what they say and put it in quotation marks because it's what they said and it's subjective. But they may say, I went to my doctor and he was real concerned about my blood pressure and I'm having a little bit of chest pain and I'm a little short of breath. Those are what he says, but you can also observe that. So you're getting right there subjective and objective data at the same time. Your knowledge level of your patient, do they know about their situation? And what do you know? And then the support systems. Do they have someone there that can help them? If they speak only Spanish, do they have someone that can interpret, or does a hospital provide an interpreter? Or maybe it's an elderly, frail person and they rely on their husband or their children to speak for them. And sometimes that may make a difference in what you do. So there's a lot of things that we have to take into consideration. Clinical reasoning and clinical judgment, and you hear about critical thinking, these are all kind of run together. Clinical reasoning, you put things together. You have to analyze and interpret the data that you've gathered before you start a plan of care. If you do this prematurely and you don't get all the information you need, i.e., maybe your patient has high blood pressure, and you notice on their med list that they take a diuretic and you don't know their potassium level, that would be a really good thing to do because that could totally change what you do. So you need to put all the pieces of the puzzle together, and you'll learn how to do it quicker and quicker as you get more experience. And you need to look at things and say, okay, this is what's going on. My patient's short of breath. Their oxygen saturation is 90 on room air, and their blood pressure is elevated. Okay, I need to raise the head of their bed. I need to put some oxygen on them. I need to call the doc and get some orders for this blood pressure. Those are kind of things that call clinical reasoning, and then what you should do based on that. The outcome of your assessment is a portrait of the patient's physical status, okay, their strengths and their weaknesses, their abilities, their support system, their beliefs about health, and their activities that they do to maintain their health, as well as their problems and any available resources to help them. And so lots of times as you're admitting your patient and you're getting that comprehensive health assessment, there are things that will come up on your electronic record there that when you click a certain thing, it will automatically give that patient a referral to social services, and social services will come up and see, or the discharge planner, and see what that patient needs to help them maintain health after discharge or at home. So there's a lot of components here, as you can see. So this is how nurses make judgments about what should I do. Should I call? Should I do some first, then call? Do I need to get help? Do I need to get another opinion? Etc., etc. And as you can see, we interpret. Okay, I interpret that my patient's blood pressure is low and their skin is cool and pale and they're having difficulty breathing. What I need to interpret that rapidly, and I need to respond in an appropriate way. I'm going to notice, I'm going to reflect, I'm going to do all these things. And as you see, there's a lot of things that go into this. And of course, the big thing at the bottom is the context. Do I notice things? Do I notice things are not quite right? It could be very subtle. There's where your observation, your inspection, you're just being aware of how your patient is in that moment makes a big, big difference. This is kind of on that same order. It's a nursing process. The nursing process consists of assessment, making your nursing diagnosis, making your outcomes, planning what you're going to do to meet your outcomes, going ahead and implementing your outcomes, your interventions, and then evaluate. Did it work? And so your assessment is the very first step. Without an assessment, you are pretty much ineffective. And making your assessment and then looking at your assessment data and say, yes, sir, this is what's going on. I'm going to go ahead and give a preliminary, maybe nursing diagnosis. And then as I go along, I may need to revise that. My outcome identification, it could be something as simple as your patient says their pain is an 8/10. Your outcome might be the patient will verbalize that the pain level is down to a 3 within an hour. And then your interventions might be, I'm going to plan to administer the prescribed medication, then I'm going to give it, I'm going to do other things, and then I'm going to go back and say, how's your pain? The patient says, oh, it's not an 8 anymore, it's like a 6, and it's going, you go back a little bit later, oh, it's great, it's down to a 3. So those are how you do this, and you're going to learn a lot about the nursing process. You're going to hear it over and over. Data analysis, interpretation, and clinical judgment include, and we've also talked about this a little bit, you'll know, and when you're in health assessment, we teach you what's called, in quote unquote, normal, okay, what we would anticipate to hear or see when you are doing an assessment, and even in your first semester and you're in clinical and you put your stethoscope on someone's chest and you're listening to their lung and you hear something wheezing or lots of crackling and gurgling, you know right off the bat, or you should know, you will know, that that is not right. I don't know what to call it. I don't know what the diagnosis is. I'm not here to make a medical diagnosis. I am here to notice patients' changes and make clinical judgments and interventions based on what this patient needs. Correctly interpreting findings, and again, you'll learn this as you go. You'll learn what's appropriate and what's important and what isn't. Applying clinical judgment to these interpretations and about their needs or concerns or problems, and then after understanding your situation, you respond by determining what you should do that's appropriate, that would benefit the patient the most. And we always talk about health promotion and health protection, especially health promotion. We as registered nurses need to promote healthy living. We don't want people to be ill. We want them to be healthy. And so um, health promotion is behavior that's motivated by a desire to increase well-being and actualize health potential. In other words, I need to quit. I need to lose 10 pounds. Okay, I need to do that. And so I'm going to help my patient says I want to do this. I'm going to help them by maybe putting them in touch with a dietitian to come up with an eating plan that will help them lose 10 pounds. And they realize how important it is to maybe include exercise, and they say, I really want to get healthy. Great, we're gonna help them. We're gonna promote that. We want them to get more healthy. And then, of course, health protection is behavior motivated by a desire to avoid illness, detect illnesses early, and maintain functioning when we're ill. So to avoid illness, we do things like the flu shot. We give the children the vaccines, etc., etc. We detect illnesses early. Women have women exams and mammograms, and maybe we do the colon detection kits. Those are things that if we find things early, we're a lot better off. We can treat them better. We have better outcomes. And then, of course, we want to maintain functioning while they're ill. They may have a chronic disease, but we might be able to help them have a better quality of life by intervening with physical therapy, assistive devices, etc. So the framework for health promotion is found with the Healthy People 2020. There's a website that has some really good information on there. I would suggest that you at least visit it. These objectives that we have for healthy people addresses the most significant preventable threats to health, with goals to reduce threats, things like obesity, heart trouble, high blood pressure, etc., etc. And they have some it's really interesting, and you may hear more about this in another course, possibly in your leadership or other courses as you go through the curriculum. And there are our references.